endocarditis is high. And 5 weeks, there is a risk of thromboembolism, and 5 months, peripartal cardiomyopathy risk is high.
Yes, I mean, it's I think a very innovative or mnemonic kind of thing to whatever we discuss. Yeah, you remember them. Yes.
Thank you, sir.
Thank you, Dilip sir. Thank you, Jessie ma'am, for the wholesome and wonderful discussion. And the presenters also did very well. All the best for your exams.
Thank you, ma'am.
Yes, next we'll go to the last topic for today. The topic is fibroid and fibroid uterus, and the moderators are Dr. Anuradha ma'am. Ma'am is a professor and HOD of OBG department in Chettinad Medical Hospital, and she is also an university gold medalist. She has been also received the Best Doctor Award by the Chromepet Lions Club. And the second moderator for today is Pallavi ma'am. She is a professor in Department of OBG in Mahatma Gandhi Medical College, and she has got 14 years of teaching experience. She is member of Foxy and PCOS Society of India. Welcome, Pallavi ma'am and Anuradha ma'am. Presenters, kindly introduce yourself and you can start sharing your presentation.
Good evening to everybody.
Good evening, ma'am. Dr. Mahati.
Anuradha madam, welcome.
Anuradha madam
Let's make it slide share.
and program chairperson. पर तू याद रखना निकालने के लिए अगले साल. सुनीता.
Ma'am, is my slide visible?
Yes, yes, you can proceed.
Slide is visible. You can start your presentation.
My topic is on fibroid uterus.
Can you switch, Priyanka, can you switch on your video? We can't see you. Yeah.
Mrs. X, a 45-year-old female hailing from Kelambakam, who's a homemaker by
Priyanka,
occupation.
wait for just 2 minutes. Our HOD wants to speak.
Recording in progress.
Madam Anuradha.
Hello, madam. How are you?
Yes.
Madam
Fine,
Pushpa.
madam. Welcome you for this program, madam. Pallavi, welcome,
good
ma.
evening, madam. Thank
Good
you,
evening, ma. Good evening.
Can I start, ma'am?
Yes.
Yes, Priyanka, you can start.
Mrs. X, a 45-year-old female hailing from Kelambakam, who's a homemaker by occupation, belonging to socioeconomic class 3, came with complaints of heavy menstrual bleeding for the past 6 months, pain during menstrual cycle since 3 months, and abdominal distension for the past 3 months. History of presenting illness. The patient was apparently asymptomatic 6 months back, after which she had heavy menstrual bleeding associated with passage of clots lasting for 5 to 6 days. She gives history of changing 4 to 5 fully soaked pads per day. She gives history of intake of oral medications and injections prescribed by a local physician to control the bleeding. The patient also gives history of lower abdominal pain during cycles since 3 months, lasting for 3 to 4 days, spasmodic in nature, radiating to the back and lower limbs, with subsides on painkillers. She has a history of lower abdominal fullness since 3 months associated with the palpable mass. No history of burning micturition, fever, dysuria, loin pain, increased frequency of micturition, difficulty in initiation of stream of urine or urgency of urine. No history of constipation. She gives history of fatigue, palpitations, and weakness on exertion. No history of breathlessness. No history of excessive bleeding post cuts or wounds. No history of dyspareunia. No history of amenorrhea. Menstrual history.
1 minute, go back, Priyanka.
Yes, ma'am.
Why did you ask the history of amenorrhea?
Ma'am, because she's having abdominal fullness, it can even be because of pregnancy, ma'am. She's 45 years old. It's not now. We have to rule out pregnancy, ma'am.
Okay, why burning micturition, fever, dysuria?
Ma'am, it may be because of any fibroid which is the lower segment which is pressing on the bladder, ma'am. There can be history of stasis and which can cause burning micturition, UTI, cystitis, etc. Ma'am.
Okay. Okay.
Which type of
Should you-
fibroid will cause this type of urinary symptoms?
Cervical fibroid, ma'am.
Any
Should you
other?
add?
Any other site of fibroid which can cause these urinary symptoms?
Ma'am, broad ligament fibroid, ma'am. It can cause hydroureteronephrosis, giving
No,
rise
no.
to
Here,
point.
with regards to your history, you have taken regarding frequency of micturition, difficulty in initiation. So which other type of fibroid do you think can cause such symptoms? One is cervical fibroid, that's fine. What else?
Subserosal fibroid, ma'am.
So where should that subserosal fibroid be?
In the lower
You have to
uterine
tell.
segment, ma'am.
So it should be in the pouch of Douglas. Sometimes when it is impacted in the pouch of Douglas, or there is a posterior wall fibroid. So what will happen is it will push the cervix up, isn't it?
Yes, ma'am.
Again, if there is an anterior wall fibroid, that may also cause irritation of the dome of the bladder. That can lead to frequency. Yes?
Yes, ma'am.
Okay.
Should you ask about intermenstrual bleeding?
Yes,
Which you
ma'am.
omitted. Why?
Ma'am, I've asked about intermenstrual bleeding in the menstrual history, ma'am.
Okay. Okay, fine.
Can I go ahead, ma'am?
Yes.
Menstrual history or LMP was on 16/2/2022. Previous LMP 16/1/2022. Menarche attained at 12 years of age. She has 5 to 6 days by 30 cycles, which are regular in nature. She gives history of passage of clots and pain during cycles, which is spasmodic in nature, radiating to the back and lower limbs. She gives history of changing 4 to 5 fully soaked pads per day. She also gives history of change of pad during the night. No history of intermenstrual or postcoital bleeding.
What is the significance of menarche here?
Ma'am, early menarche can cause can predispose to fibroids, ma'am.
Okay.
Can I go ahead, ma'am?
Yes, ma'am.
Obstetric history. Her obstetric score is P3L3. First pregnancy, boy baby, delivered vaginally at full term. Birth weight 2.8 kg, delivered at GH 25 years back. Antenatal, intranatal, and postnatal periods were uneventful. The child is alive and healthy. Second pregnancy was also boy baby, delivered vaginally at full term. Birth weight 3 kg, delivered at GH 22 years back. Antenatal, intranatal, and postnatal periods were uneventful. The child is alive and healthy. Third pregnancy, girl baby, delivered vaginally at full term, birth with 3.2 kg, delivered at GH 19 years back. Antenatal, intranatal, and postnatal periods are uneventful, alive and healthy. Patient underwent puerperal sterilization post-delivery. Last childbirth was 19 years back. Contraceptive history, no history of usage of contraception between pregnancies. Past history, she's not a known case of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, epilepsy, cardiac, thyroid, renal, hepatic disorders, or bleeding disorders. History of puerperal sterilization done 19 years back. No history of blood transfusions in the past. No other surgeries in the past. Family history, no history of medical disorders or bleeding tendencies in the family, no history of cancers in first degree relatives, no simpler complaints in first degree female relatives in the family. Personal history.
What do you mean by, Priyanka, what do you mean by similar complaints? Which complaints have you asked? Whether it is similar in the family?
Ma'am, any abnormal uterine bleeding, ma'am, previously in the family.
Do you think abnormal uterine bleeding runs in families? Or is it
Fibroid,
specifically you want to ask something? Yes.
Any history of fibroids in the family, ma'am? Any history of hysterectomy which is done for the for fibroids, ma'am?
Okay, so you have to specifically tell. You cannot tell similar complaints in the family.
Okay, ma'am. Personal history, normal bowel and bladder habits, history of reduced sleep cycles during cycles as the patient gives history of changing pads at night, normal appetite, no history of smoking, alcohol consumption, or addiction to tobacco or drugs. Drug history, no history of drug allergy. History of intake of multivitamins since 2 months prescribed by general physician. History of injections and oral drugs during cycles to reduce pain and bleeding. The details are not available with the patient, ma'am. Coming to the summary, Mrs. X, a 45-year-old housewife from Kelambakam belonging to socioeconomic class 3 with an obstetric score of P3L3 with previous 3 full-term normal vaginal deliveries with last childbirth 19 years back, sterilized with no known comorbidities, has come with complaints of heavy menstrual bleeding, pain during cycles and lower abdominal fullness for further evaluation and management.
So based on your summary, what do you think can be the cause of all these complaints in this patient?
Ma'am, I would broadly classify it as AUB, ma'am, because she's complaining of heavy menstrual bleeding and ma'am. AUB can be classified further into structural and functional.
So based on your history, you thinking it's a case of abnormal
abdominal
uterine
uterine
bleeding.
bleeding, ma'am.
But you also said that she complains of abdominal swelling.
Yes, ma'am.
So both these put together,
Ma'am, it can either be adenomyosis, ma'am. It can also be a leiomyoma, ma'am.
So you are thinking in terms of more of structural abnormalities,
Structural abnormality, yes, ma'am.
Okay.
could it be any malignancy? Could you get
Yes, ma'am. It could
abdominal
be
swelling?
ovarian. Yes, ma'am. Ovarian malignancy we can suspect also, ma'am.
Is it common? Which type of ovarian malignancy can produce this type of bleeding?
Bleeding in hormone secreting tumors, ma'am. Granulosa cell tumors.
Any other malignancy where there is distension of the abdomen?
Endometrial CA.
Endometrial CA also. Sometimes no, they present with abdominal swelling. Of course, in this age group, it may not be, but still that also you should keep in mind.
Okay.
Okay.
Can I go ahead with the examination, ma'am?
Yes.
Examination, the patient is moderately built and nourished, no gait abnormalities, height 157 centimeter, weight 58 kgs, BMI 23.58 kilogram per meter square, pallor present, no icterus, no clubbing, cyanosis, lymphadenopathy or pedal edema. JVP was not found to be elevated.
How BMI is important in this case, no?
Ma'am, in obese patients, fibroids are more common, ma'am, and even malignancies can be common in obese patients, ma'am.
Which malignancy?
Endometrial CA, ma'am.
Okay.
Coming to vitals, pulse rate 90 beats per minute, regular in rhythm and volume, no vessel wall thickening, no radioradial or radiofemoral delay, BP 120 by 80 millimeters of mercury, measured in the right arm in sitting position with the sphygmomanometer at the level of the heart, respiratory rate 18 per minute, SpO2 99% in room air, temperature 98.2 degrees Fahrenheit.
What is the significance of blood pressure in this case?
Ma'am, patient can be hypotensive also because of excessive blood loss, ma'am.
Okay.
And hypertension, even in cases of like if there's failure also, ma'am, we can rule out failure because she's bleeding heavily.
No, with regards to your patient who's having heavy menstrual bleeding, has an abdominal mass, and then she's hypertensive, what else comes to your mind?
Endometrial CA.
It can be endometrial CA also. Okay. Is there any relation between hypertension and fibroid uterus? It's a risk factor. Those patients who are having hypertension, it's a risk factor for developing fibroids later on. Okay, so that is the significance for hypertension in your case.
Okay.
Okay, fine. Just can you tell me, just to finish, the various other risk factors, since we're discussing the risk factors of fibroid uterus, can you tell me the other risk factors?
Ma'am, nulliparity, early age of menarche,
Yes.
obesity,
Yes.
family history, ma'am,
Yes.
ethnicity,
Yes. Which race?
blacks and
Okay. Then.
Asians, ma'am.
Yes.
And
Anything else?
Ma'am, reproductive age group, hyperestrogenism,
What about the diet? Is there any role of diet?
a high fat diet,
Yes. Anything else? Any deficiencies, you know? New studies have come up. This deficiencies may be related with fibroid uterus.
ma'am, calcium deficiency, ma'am,
Vitamin D deficiency.
vitamin D.
Okay.
Okay,
Even
ma'am.
the high glycemic index diet. So all these dietary factors, it's better when you take a history, you should also inquire of these factors because there
Okay,
is a lot of association between this diet and the onset of fibroids in the patients.
Okay, ma'am.
Okay. Yes, you can proceed.
Systemic examination, CVS S1, S2 heard, no murmurs. RS normal vesicular breath sounds heard, bilateral air entry present, no added sounds. CNS, no focal neurological deficit. Spine was found to be normal, no kyphosis, scoliosis or lumbar lordosis. Breast, bilateral breast was soft, no palpable lumps or lymph nodes in the axilla. Thyroid normal, no goiter and enlargement noted clinically. Can I go ahead, ma'am?
Yes.
Per abdomen inspection, subumbilical fullness noted. Umbilicus was found to be inverted. All quadrants move equally with respiration. Subumbilical scar noted and appeared to be healthy. No other scars or sinuses or dilated veins. Hernial orifices appear to be free. Can I go ahead, ma'am?
Yes.
On palpation, abdominal girth was found to be 96 centimeters measured at the level of the umbilicus. All inspective findings were confirmed. Uterus was found to be irregularly enlarged to 24-week size. The surface was found to be smooth. Margins were well defined except for the lower margin. Consistency was firm. No tenderness elicited. Side-to-side mobility present. Lower pole could not be reached. No palpable fetal parts. Rising test was positive. Can I go ahead, ma'am?
Okay.
What do you mean by rising test, ma'am?
Ma'am,
What
when
does
you
it
ask,
indicate?
ma'am, when the patient, when you ask the patient to rise her abdomen, we can find the mass moving forward, ma'am. It just shows it's not fixed to the retroperitoneum, ma'am.
Okay.
Percussion, dull note noted over the lower abdominal mass. Auscultation, bowel sounds were heard. On pelvic examination, first speculum.
Priyanka,
Yes,
when you're
ma'am.
doing the percussion, can you go back?
Yes, ma'am.
Yeah. When you do the percussion, what exactly are you trying to find out? She's having a lower abdominal mass. Okay. So you are doing a
Presence
percussion.
of
She's
free
45
fluid,
years old.
ma'am.
Huh?
Presence of free fluid in the abdomen.
Yes. So you have to see for presence of any ascites. What is that test done? What is
Sorry,
that
ma'am?
called as?
Shifting dullness, ma'am.
Yeah. Okay.
By a pelvic examination, per speculum examination, cervix was appearing to be healthy, vagina appears to be healthy, bleeding through the os was present. On per vaginal examination, cervix is found to be in mid position, uterus corresponds to 24-week size, irregularly enlarged, mobile, non-tender, no nodularity in the pouch of Douglas. Per rectal examination, rectal mucosa was found to be free.
If there is nodularity, what does that indicate in the pouch of Douglas?
It can indicate endometriosis, ma'am.
Okay. Anything else?
Pelvic inflammatory disease, tuberculosis.
Tuberculosis will
malignancy?
not cause nodularity. Huh?
Any malignancies, ma'am, like fixity to the pouch of Douglas can show that there's malignancy, ma'am. Any nodes?
See, now by your examination, you are more inclined towards the mass being a uterine mass, isn't it? So now you think about any uterine mass which can present with nodularity in the pouch of Douglas.
CA endometrium.
CA endometrium.
Yes, ma'am.
Anything else? Any other malignancy?
CA cervix.
Why there will be nodularity in CA cervix?
Involvement of
Such a
parametric.
big mass, 24-week size.
Metastasis, ma'am.
So in case of fibroid uterus, what is the malignancy you are more worried about? though it's very rare.
Leiomyosarcoma, ma'am.
Okay. What else you can find out from your PV examination? Any other particular test we do to differentiate the origin of the mass?
Groove sign, ma'am.
Yes, anything else?
Side to side mobility.
How can you
Cervical
know?
motion tenderness. Cervical
Okay.
motion, whether the mass moves with cervical motion.
What is that called as? What is it called as? Transmitted
Transmitted mobility.
motility test. Okay. So that will tell you about the mass arising from the uterus, or it's an adnexal mass, isn't it? Okay. Fine. Yes, you can proceed.
Coming to the summary, Mrs. X, a 45-year-old housewife from Kelambakam belonging to socioeconomic class 3 with an obstetric score of P3L3 with previous 3 full-term normal vaginal deliveries with last childbirth 19 years back, sterilized with no unknown comorbidities, has come with complaints of heavy menstrual bleeding, pain during menstrual cycles and lower abdominal fullness with normal BMI, stable vitals and pallor on general examination. Abdominal and pelvic examination shows uterus irregularly enlarged to 24-week size, firm, mobile and non-tender, probably a cause of AUB with leiomyoma for further evaluation and management.
Why did you think of leiomyoma first? Tell me the points which are in favor of leiomyoma from your history and examination.
Ma'am, the first uterus is irregularly enlarged. From history, ma'am, there's no triple dysmenorrhea, ma'am. We can rule out adenomyosis, ma'am. Most commonly, triple dysmenorrhea is seen in adenomyosis, ma'am.
So you have to start from the age parity. Now, the age of the patient is 45
Patient
years
is 45
old. Okay?
years old, ma'am. And parity, she's para 3, live 3, ma'am.
Okay. So that is in favor of, more in favor of, multiparity is more in favor of?
Multiparity is more in favor of adenomyosis, ma'am.
Okay. Then? What else?
And heavy menstrual
So tell
bleeding.
from your history, what is the main findings which have made you think in terms of AUBL?
AUB, next is heavy menstrual bleeding, pain, ma'am, abdominal fullness also, ma'am.
Okay.
And early
So
menarche.
adenomasis also can cause abdominal fullness. There can be a mass.
Yes, ma'am, but here it is, she's saying mass is like 12 weeks, not more than 12 to 14 week size.
Okay, so size of the uterus is one factor which
yes,
makes your diagnosis more in favor of fibroid. It's a 24-week size mass,
yes,
isn't it?
yes,
And then something else you had said?
ma'am, and early menarche also, ma'am.
No, she is not having early menarche. She had menarche around 12 years of age. That's fine. What else in your examination?
Ma'am, on examination, the mass is irregularly enlarged,
Yes.
ma'am.
So an adenomatic uterus, how will be the enlargement? It will be more
regular, uniformly enlarged, ma'am.
uniformly enlarged. Here the
And there'll
mass
be
is small.
tenderness also, ma'am, on palpation.
So here it is irregularly enlarged.
Enlarged and non-tender also, ma'am.
Can it be still, it's a uniformly enlarged uterus, but it still can be a fibroid?
Yes, ma'am.
What type of fibroid?
Ma'am, it can be broad ligament fibroid, ma'am.
No, broad ligament, it will be irregularly. You will feel one mass on the side. I'm saying it's a uniformly enlarged uterus,
Intramural.
but it's still a fibroid.
Intramural, ma'am.
Yeah, it's mostly a submucosal fibroid. If somebody has answered, it's a submucosal fibroid which can cause a uniform enlargement. Okay, so you'll be confused there with your adenomatic uterus. Okay. Okay. So now you're thinking more in terms of AUBL based on your examination findings. Yes?
Yes, ma'am.
Because your risk factors are not much in favor of fibroid uterus. She is a multiparous woman. There's no other risk factors. BMI is normal, not hypertensive, and even no comorbidities. So more in favor of all these things are against fibroid, but your examination is more in favor of a fibroid uterus, isn't it?
Yes,
So now how you're going to proceed further?
ma'am, I would like to go ahead with routine blood investigations, ma'am. because she's already having pallor, she's bleeding very heavily. I would like to go ahead with a complete blood count to rule out anemia, ma'am.
In your general examination, how can you check for anemia?
Ma'am, like we can see the lower
Okay, so you'll see for the pallor. Okay.
Yes, ma'am.
So what are the other general examination findings you can find in a case of fibroid uterus?
Ma'am, there can be pedal edema because of congestion of pelvic veins, ma'am.
Yes.
The mass pressing on the veins.
Yes.
They can.
Can they present with fever?
Yes, ma'am. They can present with fever, ma'am.
Which type of fibroids do you think can present with fever?
Degenerations, ma'am. In degenerative
Yes.
fibroids, especially red degeneration, ma'am.
Okay. Then can they present with some syndrome where there will be cutaneous leiomyomas also? Do you know of any syndrome where fibroid uterus is associated with skin lesions? Okay, so it's called something called as Reed syndrome.
Reed syndrome.
Reed syndrome. Okay, there will be multiple cutaneous leiomyomas associated with fibroid uterus.
Okay.
Okay, so these are some specific findings you can get in a case of fibroid uterus in the general examination.
Okay, ma'am.
Okay. Okay. So, yeah. So, investigation was the first thing you're going to do?
Ma'am, I would like to do a complete blood count because she's already having pallor and she's complaining of heavy menstrual bleeding also, ma'am.
Okay.
And then I would like to do all the routine blood investigations, including the blood sugars, RFT, all the preoperative investigations, urine.
So you
routine.
have already have decided that it is a fibroid, have you? You have just
Not
done a
yet, ma'am.
hematology and
Not
then you
yet,
are
ma'am.
telling preoperative. How are you going to
No, ma'am.
confirm your diagnosis?
Ma'am, by an ultrasound, ma'am.
So tell me about ultrasound. What's the role of ultrasound in fibroid uterus?
Ma'am, the ultrasound can we can distinguish if it is any other if it is adenomyosis or any other or an ovarian mass, or if it is a fibroid itself, ma'am, on ultrasound examination. So
can you give the description of fibroid in ultrasound? How it looks?
Ma'am, it's a hypoechoic, well-defined mass, ma'am.
It need not be always hypoechoic. It depends on many things. It can be even isoechoic, or it can be hyperechoic. Okay, and you can get calcification also. Okay, but it has to be a well circumscribed mass. Yes. What else will you see?
Any increased vascularity, ma'am.
Okay.
Number of fibroid, size of the
Yes.
fibroid, location of the fibroid.
So what is this called as when you're doing all these things? You're seeing the size, number, location, how it is going to help you?
Fibroid mapping, ma'am, to plan the further treatment, ma'am.
And what
Further
treatment, if you're planning, you would like to do all these things?
Ma'am, we can try a conservative management, or if it is
So
like
if you're planning a conservative surgery like?
conservative surgery like myomectomy, ma'am.
Yes, so there you need to know exactly what are the numbers of fibroid, okay?
Yes,
What's the site of fibroid? So you can decide even about the type of myomectomy you are planning, isn't it? Okay, what else will you see in the ultrasound?
ma'am, endometrial thickness, ma'am.
Okay, why you want to see the endometrial thickness?
She's complaining of heavy menstrual bleeding also, no, ma'am. So we would like to see the heavy, like the endometrial thickness, if there's any endometrial hyperplasia.
Okay, so
Or any
because,
polyp.
yeah, so because of hyperestrogenism, you can get endometrial hyperplasia also. Okay,
Yes,
anything else?
ma'am, we have to check the adnexa also, ma'am. For
What
any
you want to see in the
ovarian
adnexa?
any cyst in the ovary, any ovarian mass.
What type of cysts are commonly associated with fibroid?
Functional cysts, ma'am.
Which type of functional cyst?
Hemorrhagic cysts.
No.
Simple cyst.
No, what are the types of functional cysts? Can you name the functional cysts?
Corpus luteum.
Yes, what's the other one? Yes, follicular cyst, somebody has answered.
Follicular cyst.
So you tend to get such follicular cysts in a case of fibroid uterus. Okay? Okay. Anything else? In the ultrasound? It's a big one. It's a 24-week size fibroid, isn't it?
Yes, ma'am.
What else you
Abdominal
expect?
ultrasound also, ma'am, for ruling out hydrouretronephrosis, ma'am.
Yes, yes. So can you tell me what are the types of fibroid which can cause compression on the ureter?
Ma'am, one is cervical fibroid, broad ligament fibroid,
Yes.
pedunculated fibroids.
Why pedunculated fibroids will cause compression? Mostly it is a big size fibroid, like 18-20 week of fibroid, which is resting on the pelvic brim. So they tend to compress the ureter at that brim. Okay, then you have the broad ligament and the cervical fibroids also, which can cause hydrouretronephrosis. So you need to see this, the status of the kidneys when you are having a big fibroid. Okay. Okay. Anything else?
Any free
You
flow?
said something about vascularity.
Yes, ma'am. Any internal vascularity, any peripheral vascularity also we have to check, ma'am.
So what is the vascularity usually seen in a fibroid uterus?
Peripheral vascularity, ma'am.
So if you see increased vascularity, what else should you suspect?
Malignant change, ma'am.
Okay. So you can think of leiomyosarcoma when you see more of vascularity. Okay, isn't it?
Yes,
Okay. Okay. Then any other investigation you want to do?
Ma'am, endometrial biopsy we have to do, ma'am.
Would you like to do endometrial biopsy for all patients with fibroid uterus?
Yes.
For all patients with fibroid uterus you want to do? Or you have some indications where you would like to definitely go for a endometrial sampling?
Ma'am, we would actually, ideally we should be doing for all patients to rule out any endometrial pathology also, ma'am.
You just tell me what are the indications when you would like to do an endometrial sampling? What are the types of patients where you would definitely go for endometrial
Any
sampling?
polyps in the endometrium, any hyperplasia in the endometrium, any distortion of
See, in this patient, I would say because she's 45-year-old and more, okay, so there is the role of endometrial sampling here. Just because fibroids are there, you need not go for endometrial sampling unless she's having some irregular type of bleeding. If there is associated intermenstrual bleeding, in those type of patients, you can think of going for an endometrial sampling, or she has some other risk factors for endometrial CA. In those patients, you would like to go for the endometrial sampling. But if the patient is having a regular heavy menstrual bleeding, that means menorrhagia, in those cases, it's not required. Okay. So, yes, so that is one thing. Then anything else? What's the role of MRI? Would you like to go for MRI?
Yes, ma'am. MRI to again see the location, to see the position of the fibroids if you're planning for surgery, ma'am.
That I can detect in ultrasound also. Where is the role of MRI? It's a very expensive investigation, isn't it? So in which patients you would definitely want to go for an MRI?
If you're suspecting malignancy, especially, ma'am.
Okay. Then?
And any like
See, if there is a single mass in the uterus, okay? There's just a single mass in the uterus. You are confused between fibroid uterus and what's the other thing which can be possible?
adenomyosis.
Adenomyoma. Okay. So in those cases, where if you're planning a conservative surgery, you have to be very careful that you are dealing only with fibroid, not with adenomyoma. Otherwise, you will be stuck during the intraoperative period. There you can use MRI to differentiate. Yes, MRI is the best modality for diagnosing adenomyosis. Another is because now there are so many other newer treatment modalities which are there, minimally invasive, okay, where you want to save the uterus, like can you name some?
We can use LNG, IUCD, uterine artery embolization.
Yes. So
HIFU.
this uterine artery embolization is an upcoming technique, isn't it? So here the MRI has a role because the imaging patterns help in predicting the outcomes of UAE. Okay, so there is the role of MRI. So routinely we won't go for all patients. Where you are confused whether it's an adenomyoma or fibroid uterus, or you are suspecting leiomyosarcoma, or you're planning an UAE, in those cases, okay, yes, definitely I would think of doing an MRI. Yes. Any other investigation you want to add? Role of IVP?
Yes, ma'am. IVP, especially for compression, if there are any pressure symptoms, ma'am, and for any suspected hydrouretronephrosis.
Yes, so whenever ureter, your big fibroid, broad ligament fibroid, where the ureter is getting compressed, you want to delineate it, you can go for a IVP. Okay. Then, any more slides you want to show? That is the final slide you are showing.
Ma'am, this is final slide for the case, ma'am.
Okay. So after doing all these investigations, is there any role of HSG and hysteroscopy? Because all these investigations are given in your books. And you write all these investigations when you go for the exams.
Ma'am, for 24 weeks.
For this patient, is there any role of hysteroscopy, HSG?
No,
So where you would like to do specifically HSG?
ma'am, any submucosal fibroid, ma'am, to differentiate it with any polyps.
In which patients? That all
Infertility.
detect by ultrasound.
Subfertility or infertility cases.
So what added advantage is there when you're doing the HSG?
Even the tubal patency.
Yes, so you can see the tubal patency also. Okay, fine. Do fibroids cause infertility?
Yes, ma'am.
Yes, all fibroids cause infertility?
Not all, ma'am. Submucosal fibroids and the ones which distort the endometrial cavity can most commonly cause infertility, ma'am. And any cervical fibroid also can cause infertility.
Okay, okay. So what is the plan for this patient?
Ma'am, she's 45 years old and she's completed her family also, ma'am. So we can give her a choice, ma'am, if she wants to conserve the uterus or not, ma'am. But basically, we would like to go ahead with, since it's 24 weeks fibroid, we would like to go ahead with hysterectomy, ma'am.
Okay, so you want to plan for a hysterectomy.
Yes,
Okay, fine. What is the route you will choose?
Ma'am, abdominal route, ma'am, because it's 24 week size, we could go for an abdominal route, ma'am.
Okay. What are the advantages of doing a laparoscopic hysterectomy?
Ma'am, the morbidity is less, blood loss is less, ma'am, and post-op stay is also lower, ma'am. Post-op pain is less, post-op complications are also less, ma'am.
So some expert surgeon is there who still wants to go ahead with laparoscopy for this patient. How is going to achieve the goal of completing the surgery in this patient?
Ma'am, we could pre-operatively we can give GnRH analogs, ma'am, which will shrink the size of the fibroids.
Okay.
And then we can take her up for hysterectomy, ma'am. And intraoperatively, we can go ahead with, we can do a hysterectomy and morcellate it and remove the fibroids, ma'am.
Okay, so you can use morcellators.
Yes, ma'am.
For the big size fibroids.
Yes,
okay. So what is the role of GnRH for fibroids?
Ma'am, it will decrease the size of the fibroid, ma'am, and it will also decrease the bleeding also, intraoperative.
Does it decrease only the size of the fibroid?
The size also and fibroid.
So both the fibroid volume and uterine volume is reduced. What else? By that it decreases the symptoms.
Bleeding, intraoperative blood loss, and heavy menstrual
So
bleeding.
what are the indications of GnRH, or what are the advantages of using GnRH?
Any patients who are awaiting for surgery, ma'am, who's already anemic and we need to give blood transfusion or anything to improve their anemia status.
Okay.
Perimenopausal women, ma'am.
Yes.
And preoperatively, if they're having such large fibroids and we want to go ahead with or to reduce the size of the fibroid, we want to go ahead with the laparoscopy.
So preoperatively, one is it reduces the size of the fibroids. It will reduce the blood loss during the surgery. It can help you convert the incision from vertical to transverse. That's also a positive point. Or you can even convert the abdominal surgery to the vaginal surgery.
Vaginal hysterectomy, ma'am.
Okay, so all these added advantages are there for GnRH. What is the disadvantage?
Disadvantage, menopausal symptoms, ma'am, like pseudomenopause, so there'll be hot, already patient will have hot flashes. Osteoporosis can also occur, ma'am, if you're giving it for.
So how long can you give it?
Ma'am, we can give it maximum for 6 months, ma'am, and then we have to give add back therapy, ma'am.
Okay, so what is the add-back therapy?
Estrogen, tibolone, estrogen progesterone.
Okay, so combination of estrogen, progesterone or tibolone, these are the two commonly used ones. Okay. So if you use the GnRH, what is the disadvantage? If you're using it pre-operatively, what is the disadvantage? You told me so many advantages, but there are certain disadvantages associated with GnRH. So this
Especially in myomectomy.
myomectomy, yes.
Plane of cleavage will not be proper in myomectomy, ma'am.
Yeah. So you'll have difficulty in enucleation because you lose the plane of cleavage. Anything else?
Ma'am, if there are very small fibroids, they will be missed, ma'am.
Yes. So
giving
again,
liver,
what will happen after operation? Immediately again, there will be growth of the fibroid
recurrence
and it
will
will
be
be
there,
a
ma'am.
failure. They'll assume it to be a failure or there's an early recurrence of myomas, isn't it?
Yes, ma'am.
Okay. So coming to the same plane of enucleation. So, you know, there's the other conservative surgery is myomectomy.
Yes.
What's the indication of myomectomy?
Any patient who is desiring fertility, ma'am,
Only fertility?
fertility and any, if the patient wants to conserve the uterus, if the patient is young and hasn't completed her family. Any
Okay, so
small
both
fibroid-
conservation of uterus and reproductive function.
Reproductive function.
Okay, so there you would think of myomectomy. So can you just tell rapidly the principles of myomectomy? Principles of myomectomy. What are the things you have to keep in mind when you are doing a myomectomy?
Ma'am, we should reserve adequate blood and blood products, ma'am. We should also get
Why you want to reserve blood?
Ma'am, there is a history of, there is a risk of increased blood loss during myomectomy, ma'am. And we
So what
should
are the
also,
ways of reducing that blood loss?
we can give adrenaline, ma'am. We can infiltrate adrenaline, vasopressin, and we can.
See, the first thing is somebody has answered. First thing is bring the patient in a good hemoglobin status to the OT. Build her hemoglobin status, then only bring her to the OT. If she is already anemic, give her oral supplements. Improve her HB status. Then you bring her to the OT. Okay? Yes. Then
We should
you can-
counsel about the need for hysterectomy in case of any excessive blood loss also, ma'am.
that is counseling. We'll talk about that later.
Yes,
What
ma'am.
are the other things which can be done to reduce the blood loss?
We can vasopressin. We can use clamps, ma'am.
What clamps? Is there any specific clamp?
Bonnie's myomectomy clamp. Any tourniquet also we can use, ma'am.
Okay. Then where do we apply the tourniquet?
Tourniquet at the vessels, ma'am, uterine vessels.
Anywhere else? Is there any other blood supply to the fibroid? Is the uterine vessel the only blood supply? What is the other supply?
Ovarian vessels.
So where else can you apply the tourniquet?
And adnexa, ma'am.
Anything else we used? Adnexa means you have to tell specifically where.
The broad ligament.
Infundibulopelvic ligament. Okay. So sometimes we apply the sponge holding forceps with rubber tubings. We clamp it there along with the clamping the uterine vessels with the clamp.
Okay.
Then one is vasopressin. How much vasopressin you should give? I think all this were discussed in the first day itself. You can just tell it. How much vasopressin do we give?
Ma'am, 0.2 in 100 ml, ma'am.
20 units in 200 ml.
200
You
ml.
just remember like this 10 units in 100 ml, 20 units
20
in
units
200
in
ml.
200.
You can give like that. Okay.
Yes,
Anything else? What your anesthetic colleague can do?
Anesthesia, they can give tranexamic acid, ma'am.
No, they can give hypotensive anesthesia.
Okay.
Okay. So
Fine.
they reduce the blood pressure so that the bleeding is less.
Okay.
Okay. Then yes, you can use intravenous tranexamic acid also during the operation. Okay. So these are the few methods by which you can reduce the blood loss.
Okay.
Anything else? The most important thing is you should be in the plane when you're removing the fibroid. Okay. When you're enucleating, you should be in the correct plane. If you're not in the correct plane, there will be a lot of blood loss.
Yes, ma'am.
So that you have to ensure. Where should you put the incision?
No.
When you're dealing with the fibroid, where should you put the incision? Usually in the anterior wall,
Anterior
midline.
wall.
Okay, so you will put a midline vertical incision. Nowadays, even they are telling transverse incision is also okay. And try to reduce the number of incisions on the uterine surface. So using the same incision, you can use tunneling incisions to
Tunneling
remove
incisions to
the
remove the other fibroids.
fibroids. Okay. What is Boney-Wood's? These are all theoretical questions. What is Boney-Wood's operation? For which type of fibroid we use it?
Posterior wall fibroid, ma'am.
Fundal posterior. Okay, so usually in the fundo-posterior region, if there is a fibroid, you can use that type of incision. Okay. If at all you have to give a posterior wall incision, what are the complications associated? If you're giving a posterior wall incision, what is the expected complication?
Adhesions, ma'am.
Yes, there are more chance of adhesions, bowel adhesions. How can you prevent these adhesions? You can use adhesion barriers. Do you know the name of any adhesion barriers? Very commonly used.
Ecodextran.
Intercede. Okay.
Intercede.
Yes. And also you can plicate the round ligament so that the uterus is anteverted. It doesn't fall back. So these are simple things. And you can use a lot of fluid wash, make ensure that hemostasis is there so that the adhesions are reduced. Okay. Okay. So coming to the newer methods, can you just name and list the new methods?
Uterine artery embolization, ma'am.
Okay, then
Laparoscopic myolysis using laser, cryocautery,
Yes.
or electrocautery.
yes.
MRI guided percutaneous lasers.
Okay.
MR guided focused ultrasound.
So in this list, which are the two most important ones?
Uterine artery embolization is one, ma'am.
Yes, then
And MRFUS,
yes.
ma'am.
But what are the contraindications where you would not be able to use this type of techniques for treatment?
When the patient is desiring pregnancy, ma'am.
Yes, one is when they want fertility. Okay,
Fertility.
so you will not offer this type of technique. Anything else? Any particular type of fibroid you cannot use this? Usually in pedunculated subserosal fibroids you cannot use. And also for MRI, you cannot use if the fibroids are very close to the important organs like bladder and bowel because there's chance of injury.
Injuries.
Okay.
Yes, ma'am.
Okay. So coming to the medical management, can you just for the sake of completion, tell me something about the medical management of fibroid? What are the indications?
Ma'am, indications are if the patient doesn't want, if you are waiting for correction of anemia, if the patient doesn't want to undergo any surgery, and if perimenopausal patient.
So what are the various agents there for medical management?
Ma'am, first we can use tranexamic acid, mefenamic acid for pain relief and for reduction of bleeding, ma'am.
Yes.
And apart from that, we can also use GnRH agonist to shrink the size of the fibroid and also to wait for surgery when there is any treatment, when we are waiting for anemia.
Any other drugs which can reduce the size?
We are using ulipristal acetate and mifepristone also low dose, ma'am.
Okay,
And
so what is the maximum duration you can use these drugs?
Maximum of 3 months.
Mifepristone around 3 months. What about the ulipristal?
Ulipristal.
See, all these drugs were initially tried for 3 months. Okay, then they have tried in further studies. They have increased the duration of the treatment course to four courses. So it will come to over a period of 1 year. Okay, but they have their own side effects which you should be very careful about. Okay, and once you stop these drugs, what will happen?
It will there'll be recurrence. It will grow back to the same size.
What is the effect of these drugs on the endometrium?
Endometrium, they can be hyperplasia, ma'am.
Which drug will cause endometrial hyperplasia?
Mifepristone, ma'am.
Mifepristone. What is the effect of the ulipristal on endometrium?
Ulipristal.
They cause something called as benign endometrial changes. Okay. So you have to be careful about these things when you're dealing with the drugs for the reduction of the size of the fibroid. Okay. Okay. Madam, you want to ask anything, ma'am?
How you would take precautions to avoid ureteric injuries? Because your case is has such a huge fibroid, isn't it? Ureteric injuries.
We can first do pre-operatively we can do IVU and we can ask for stenting by the urologist, ma'am. And we can also in MRI we can see the position of the ureters also, ma'am. And we should give adequate exposure also when we are doing the surgery, ma'am. And we should not blindly clamp the vessels, and we should properly dissect the ureter, ma'am. And we should mobilize the bladder also, and we should also we should not go on the retroperitoneal approach because the ureter is a we should go on the retroperitoneal approach because the ureter is also a retroperitoneal organ, and we should stay closer to the uterus.
And the dissection should be within the capsule. Okay, should not go beyond the capsule.
Okay.
What is the effect of let us just discuss few points on fibroid in pregnancy. Okay, so can you just tell me what are the various effects of fibroid on a pregnant uterus? Fibroid on pregnancy.
More
Yes.
chances of abortions, preterm labor,
Yes.
intrauterine growth restriction. There can also be degenerative changes during pregnancy, where patient will complain with will come with fever and acute abdomen.
Okay. Then
Postpartum during postpartum.
no, anything else? Antepartum malpresentations.
Malpresentations, ma'am.
Yes. Then
During labor,
during labor, they won't be proper contractions, ma'am. The contractions won't be adequate for progress of labor.
okay, in the postpartum period.
Postpartum hemorrhage, ma'am.
Anything else?
Because of atonic PPH, ma'am, atonicity.
Anything else it can cause postpartum?
In any way, postpartum endometritis, sepsis.
Well, that is very late, immediately. After the delivery of the baby, sometimes the placenta can be just simply retained because the fibroid is there in the lower segment. So it may lead to a retained placenta, or the placenta may be adherent also because the endometrium is not very good over the fibroid. Okay. Now tell me, what are the effects of pregnancy on the fibroid?
Then degenerative changes are more during pregnancy, ma'am.
Okay, then yes.
Sometimes the size can also decrease, ma'am, because there's no not because of the
Size. The effect on size is very variable. Okay, so
Yes, ma'am.
it may increase, it may remain the same, or it may decrease also. If it increases, the growth is usually more in the first trimester.
Yes, ma'am.
Okay, then anything else? What happens to the shape?
The shape, the uterine cavity is distorted, ma'am.
No,
I'm saying maybe.
the fibroid, sometimes very well circumscribed fibroid which you can feel, but during the pregnancy, as the pregnancy advances, the delineation is lost.
There'll be axial torsion of the uterus, ma'am.
No, that what I'm trying to tell is the shape, it will get merged with the uterine musculature. So you may not be able to delineate it very well as the pregnancy advances. Okay, so that is the effect on the shape. Then, as you said, there can be chance of torsion in the subserous pedunculated fibroid. Then, postpartum.
Postpartum infections can also
Yes,
be common, ma'am.
mostly in the submucous fibroid. Okay, so there may be more chance of infection in the postpartum period. Okay. How will you manage fibroid polyp?
Polyp, we can go ahead with a hysteroscopic resection, ma'am.
If the polyp is hanging outside, will you go for hysteroscopic
No,
resection?
ma'am.
So you tell according to the.
According to the location, ma'am,
Yes.
whether it is lying outside the os or in.
So if it is lying outside in the vagina, it's a small, say 5 centimeter, 4 centimeter fibroid polyp. What are the ways you can do to remove it?
Ma'am, we can.
You can just, if
Go
it's a
ahead,
thin
clamp it
pedicle,
and remove it,
yeah,
ma'am.
if it's a thin pedicle, you can just avulse it.
Yes, ma'am.
Okay, so if it's a thick pedicle, you have to obviously clamp and
Clamp and ligate
ligate
it
it.
and then take it off.
okay. Any other way is there? It's filling up the full vagina. You can try enucleation there also.
Okay.
So that you remove the bulk and then you can tie the pedicle.
Okay.
If the fibroid polyp is inside the uterine cavity, then obviously you have to go for
Hysteroscopic resection.
hysteroscopic resection. Can you tell me is there any classification which helps you in predicting the outcomes of this hysteroscopic resection? You have heard of FIGO classification.
Classification.
That is for the just telling the anatomical classification. Any classification you know? Yes, somebody has answered. It's called step W. Okay, please have a look into it. It's called the step W classification. It helps you in predicting whether you can really go for the hysteroscopic resection in a particular submucosal fibroid or not. Any other classifications for submucosal fibroids other than the FIGO and this step W? Any other classification you know? That's something the European Society classification is there.
Okay.
Anybody knows? Okay, so along with the amount of the fibroid which is projecting into the endometrial cavity, they also see the angle made by the border of the fibroid with the uterine wall. Okay, so type 0 is when it is completely inside the uterine cavity. Type 1 is where it is less than 50% intramural and the angle made is acute angle. It is less than 90 degree. And type 2 is when more than 50% intramural and the angle is 90 degree or more. So that is the SG classification. These are the three important classifications for submucosal fibroids. Okay, so any other questions? Madam, anything else you want to add? Please add. Anuradha madam.
You have almost covered everything, ma'am. Any questions from the students? Many of them have left, I think.
There are no questions, ma'am. They've actively answered to many questions you have asked.
Yes, yes.
Yes.
Participants.
So they have gained a lot of knowledge in these last 2 days.
I'm sure of that, ma'am.
Yes, yes. Okay.
Okay.
Okay, ma'am.
Thank you, Doctor.
Okay, Priyanka.
Thank you so much, ma'am.
Thank you,
Priyanka, you
Anuradha,
presented
ma'am.
well.
Thank you,
Yes.
Pallavi.
Answered well also.
Thank you,
Okay.
Priyanka. You have
And
presented
Pallavi, you took the discussion very well.
Thank you.
It was nice discussion.
Still, I think a lot of things are there, but the time is
Yes,
very
but there is
short.
a time constraint. Yes.
Yeah, yes.
Thank you so much, ma'am. With this topic, we have come to the end of the session today. I hope all the participants would have enjoyed the whole day thoroughly. And the last session, they had so many exam questions and many important questions were discussed today.